We are privileged to have Dr. Michael Sauri, KA3IXO, with us tonight to present an update on COVID-19 and its variants. Some of you will recall that Dr. Sauri, who was a member of our club and also an infectious diseases expert, gave us an initial briefing when the pandemic was still in its early stages back in April of 2020. Here we are 2.5 years later, and so much has happened in the interim. So we are very excited to have Dr. Sauri here to give us an update. So thanks for joining us, Doctor. And now it's over to you.
All right. Well, thank you very much, Alex, and the board for inviting me to talk about a subject that is not dear to my heart, but I've been dealing with it for 2.5 years, so I'm familiar enough with it. But let me share my slide. And can everybody see that?
Yes.
Okay. So I'm going to talk about some key points first that may stimulate some questions that some people have. And then I'm going to sort of cover where the ACIP, a CDC committee that determines final approval of vaccines, is coming from when they made the approval of the new upgraded vaccine called the bivalent vaccine of both Pfizer and Moderna. I'll also just talk about where we are globally in the US and in Maryland with respect to COVID. So what's happened was something that we had seen in all terrible viral pandemics, is that it's moved from an epidemic to an endemic phase. And each variant that comes out tends to be less virulent, but is more infectious in order to improve its survivability. And there's no advantage for it to kill the host too quickly, and it can't spread. We have a great antiviral, Paxlovid, that has been shown to be 89% effective in reducing severe disease and death. You can think of it like Tamiflu for the flu. And since late December of last year, over 100,000 5-day courses have been dispensed in Virginia. And nationwide, they're dispensing about 160,000 a week. And it's usually for the high-risk individuals who are likely to suffer from a COVID adverse effect or infection. So at this point, slightly half of those that are fully vaccinated, which is about 1/3 of the population, has opted to get the booster shot, the number 3 shot. And as of August 29th, there actually has been a 30% drop in cases. In the past 2 weeks, there's been 10% drops in hospitalization and death rates. And currently the rate the daily rate is 90,000 cases in the US, 38,000 admissions, 4,600 ICU admissions, and 480 deaths on a daily basis. On 8/11/22, CDC, because of these statistics, revised their guidance to remove key restrictions, mask mandates, lockdowns, things like that, and isolation or quarantine for people who had been vaccinated. On the 8/17/22, the CDC actually made an apology for some of their mistakes. And there's been lots of accusations, and at least in the medical arena, of misinformation and collusion with the big tech and public health officials and the media. There's lots of examples, but CDC, essentially this August, CDC finally admitted that there was a value for natural infection, immunity from natural disease. We call it active immunity. So now you can add 94 million people to the herd immunity statistics that weren't included because of their prior feelings about the value of having natural immunity. And they started to downplay the rhetoric of the pandemic of the unvaccinated and things like that. Other key points that I'm just bringing up to kind of refresh your memory of what's been happening just in the past month is that the variants of concern like BA4, BA5 continue to dominate. BA5 makes up close to 80% of everything that's coming down. All the patients that are sick tend to have that one. And some of the other lineages are still in low prevalence rates, but it's mutating, but it's having to compete against very fit variants like BA4 and BA5. This month, the Biden administration ended free at-home antigen testing or ordering. Part of it was because Congress didn't fund it, but it may create a problem for people who don't have access, especially with the economy the way it is, to afford a $25, two-pack test. There's also been a growing realization ever since the COVID vaccines have come out that there is a limited durability to the antibody and T-cell response. And because of that, you're starting to hear them talk about the need for more frequent boostering. And you might have heard about the heterologous mix and match vaccine, where if you had Pfizer, get a Moderna booster or vice versa to try to improve the response with the original vaccine platform. This was obviously the vaccine that was aimed at the old spike protein. Also, at the end of August, the FDA amended the EUA for both Moderna and Pfizer to authorize them to use their bivalent formulation. It will be a single boost vaccine initiative. These bivalents are referred to as updated boosters. They use the same platform. Because of that, they were considered biosimilar biologics and didn't have to undergo all of the hurdles that Pfizer and Moderna had to do with the original vaccines. But the reason they call it bivalent is because they're actually using two messenger RNA components, one from the original strain and one that is of the Omicron variant for BA4, BA5. So this will actually target more specifically what's circulating out there. And also at the end of the month, the last month, FDA is no longer authorizing anybody to receive the previous vaccines unless you're one of the few that are wanting to start the primary series. They will allow you to use that. So those are kind of, things that sort of have happened recently, and it may stimulate, some thought as to where we might be going or where we should be going. We do have monoclonal therapies that have been shown to be pretty effective. And some of them are not as effective as others, but we are using all of them for certain indications. Most of these monoclonal therapies have to be given in infusion centers or hospitals. The antivirals have significantly been the major game changer here. Remdesivir, though we've used it ever since almost the beginning of the pandemic, never really did as well as these newer agents that we're dealing with at the present time. Langrioria, which is the molnupiravir, and Paxlovid are major game changers. Paxlovid is very similar to what I used with my AIDS patients since 2000. We have used it very effectively. It uses two reverse transcriptase inhibitors, one of them simply to boost the other, Norvir to boost the primary drug. And so we found them to be very effective. And all the side effects, like the drug interactions, we've known about, and the side effects. So we know the relative safety of these particular agents, and they seem to be very effective. What I'll be talking about at the end, after I sort of give a brief rundown of where we are with the pandemic, is the process by which the Advisory Committee on Immunization Practices, or short ACIP, has the criteria, the data that they have used to try to determine the question, should we be using the updated bivalent vaccine booster or not? And their vote was yes. But I'll try to explain why that's the case. It's worthwhile explaining because there's been a lot of negative information about the fact that there was no phase 3 trials. There actually was a 1,400 limited phase 3 trial that was done by Pfizer, not by Moderna, that actually showed that it was effective and safe. But the focus is on the fact that they didn't do an extensive one. And for the most part, we're going to have to rely a lot on the doctors to tell us whether or not there's side effects that are developing that we weren't expecting. We don't expect any to occur with this because it's essentially the same platform. All they did was just change the target antigen. So globally, as of the beginning of this month, there have been 630 million cases worldwide. In the past 28 days, 21 million cases. There have been 6.5 million deaths in the world. And in the past 28 days, 65,000 deaths. The US has had 94 million cases and over 1 million deaths. There's been 12 billion doses of the vaccine administered worldwide to date. And the US has about 68% of their population fully vaccinated, and mainly using Johns Hopkins coronavirus research and Stanford analytics as the databases. If you trend it over time, what you're seeing is that there obviously were peaks in the beginning of the year. It seemed like everybody and their aunt and uncle got COVID the end of December, beginning of January, and that's pretty much what it shows during the holidays. But things have slowed down. More importantly, the deaths have slowed down more significantly than the case rate. And so our hospitals are pretty much easing off, can breathe a little bit easier. Their surge capacity has not been challenged for quite a few months now. Trying to get back to case fatality rates, there are countries in the world where the case fatality rate is a quarter of that, all the cases, 25%. And that is unacceptable. In Europe and in the US, it's around 1%. Putting it in perspective, seasonal flu is 0.1%. So SARS, or COVID-19, kills 10 times more efficiently than flu. Thank goodness that the variants didn't turn into worse agents. We weren't expecting them to. But the SARS that we had to deal with back in 2004 killed 10% of everyone that it infected. And MERS in Saudi Arabia kills about 30%, or a third of the people. And it's still active in that Middle East area. Ebola is one of those diseases that is too efficient a killer, and it essentially wipes itself out quickly because it it runs out of susceptibles by killing everybody too fast. And we certainly had to deal with that back in 2016. So most of the cases that you're seeing now are in the developed countries. The darker land masses like Japan has really hit hard lately with COVID, whereas for many months or a few years, they enjoyed the fact that they were islands and could limit the amount of external pressure from this pandemic. But at the same time, it's quite variable. Though Africa doesn't see a lot of cases, their mortality rate is about anywhere from 10 to 25 times that of a European country. So if you do get it, you have a greater chance of dying of it in Africa. And the death rates oftentimes more reflect the total number based on a population of 100,000. But we're still seeing that it's the developed countries that are having to deal with this particular problem. We're getting better. We used to have a 12% case fatality rate in the first month, even in the US when we were dealing with this, but we got better at it. Vaccination rates, even though we're seeing lots of vaccination in certain countries, these countries that have a lot of vaccinations are still seeing a lot of activity. But just to show you that Africa has a problem with receiving any vaccinations, and that is, I think, a blot on WHO and other countries. If you look at the cases by region, essentially you'll see that changes in new cases, changes in new deaths are pretty much in the negatives. So you're starting to see this thing sort of just quiet down. The cumulative cases over time still reflect the areas that at high risk. And the current outbreak activity is kind of varies from country to country. Right now, I would say Japan is pretty hot. When you look at the COVID deaths per 100,000, you're looking at this from the standpoint of which countries have been hit the hardest. We think we've been hit pretty hard. UK feels they've been hit pretty hard, but Peru and Brazil have pretty much had a significant die-off of their population due to COVID. The case fatality rate, some of that has to do with why they're seeing so many deaths. Are not as good, they aren't as sophisticated, and they don't have enough ICU beds and ventilators in order to keep people alive. And so, though it looks bad when you see Peru having a mortality rate of 5% when the US has 1%. Africa, most of the African countries have 25%. So trying to put it in perspective, they just don't make a big enough piece of the pie here. If you look at distribution over time of what this virus has done, the tropical countries tend to have multiple outbreaks. Temperate countries tend to have more continuous outbreaks or clusters. So it's sort of all over the place. A lot of it has to do with the climate. If you put it all together and look at trends, even if you add all the various regions together, you see that since January, things have sort of really quieted down considerably in most areas. Western Pacific is probably now one of the problem children for COVID from the WHO standpoint. Europe and Americas have made up the majority of the cases, and you can see that in this sort of representation of the cases. And obviously trending it over time, it's hard to kind of see what's happening in each of the regions, but we can kind of get a sense that things are quieting down. And when you look at deaths, also it's still the Americas and Europe that are making the majority of the deaths. So if you look at deaths, which is that solid line, you can see it's going down along with the total number of cases. And if you look at the top 8 countries where there are COVID cases in the past 28 days, you'll see that Japan, which used to be down in the bottom, has jumped up. Taiwan, which used to be down at the bottom, has jumped up. So I think that no country, no matter if they're an island or not, is immune. Activity levels, again, this little blip here in Japan sort of reflects activity levels. So if you're trying to keep track of it, it's all over the place. There are hot spots. When you get into an endemic phase, the virus starts looking for susceptibles. And so they look for populations that have been able to be protected. And then once they get an inroad into it, they're able to, with the R0 or the communicability of these variants, are able to run through those communities pretty quickly. So the U.S. statistics, as I mentioned, really are reflecting where we are now. If you look at it by state, you get a sense that, oh, okay, it's got to be the Southeast and maybe some of the Western states. And don't I want to live in New Hampshire and Vermont area? But when you look at county level breakdowns, you'll see it's kind of all over the place. And this is a little bit more exact with respect to the activity that's going on. And this is pretty much how we look at it. This was 2 weeks ago, the map on the top, and this is what we have as of September 1st. Here in Maryland, they don't have currently any Montgomery County data. They used to. Montgomery County usually does better than the other counties in Maryland, but overall, Maryland is in a low level of about 21 cases per 100,000 of population. So we're enjoying a very low amount of activity. How this impacts healthcare is that I may start to do pulmonary functions again. There may be certain surgeries that tend to create aerosols that we may start to do. We may not do as much screening pre-op for COVID when it gets to this level because it's not cost effective. And that's how it impacts us. If you look at capacity, the top part is the unoccupied beds. So we have lots of surge capacity, and you can see that the ICU bed situation is very good. So we're doing well in hospitals. If you look at states, like this is the current trend of COVID in Maryland, and you go across the river to Virginia, or you go down to the district, you'll see it's totally different. Right now, Virginia has a lot more activity than Maryland, and DC has hardly any activity. If you go to further out to West Virginia, New Jersey, Pennsylvania, Delaware, it's kind of like there's no correlation. You don't have whole areas, sections of the US that are safe. You pretty much have to stick with the statistics that you have. Maryland, DC, and Virginia create a problem because they have different jurisdictions, different approaches to handling COVID, and you can kind of see the effect of that. Florida, Louisiana, California, it's always in the news how they, in some way, are stricter or more lenient about controls, and you can kind of see right now at the very end where they are with respect to activity. Texas, Oklahoma, Arkansas, same thing. You can go to Oklahoma, there's nothing. You go to Texas, there's lots of activity along with Arkansas. So there's no rhyme or reason to it. If, let's say, you go out to the boonies, to Montana or Alaska, well, Alaska, there'd be no activity at all. So maybe that's the place to be. But you go to Montana and it's just all over the place. They're just having one after the other of these small outbreaks. So like I say, the virus will go wherever there's a susceptible. Positivity rates are looking good. They're low at the 10% level at this point, which means that of 10 tests, only one of them is positive. So most of the other reasons for the testing are not due to COVID, colds, allergies, things like that. So vaccination rates, if we look at Maryland and compare it with the US, 95% of the population in the US has had at least one dose. And the population over 5, they're close to 94%. In Maryland, we have a fully vaccinated rate of 77%. Compared to the US rate of at least one dose, they're 95%, Maryland's about 89%, and 42% have opted to get a booster. So that's pretty much where we are with it. We're not really dealing with shortages of vaccine. This is not, you can break it down. The websites are such that you can go county by county and kind of see just how they're doing by age. And the bottom line here is essentially the younger age groups are not being vaccinated. Their parents are holding back vaccinating them for whatever reason. The reality is that we are always been dealing with breakthrough infections in Maryland. Literally 1 month after the first vaccine was available, Pfizer was available, we had our first post-vaccination infection. And about, though 4 million are fully vaccinated, we're seeing that less than 9% of these fully vaccinated individuals turn positive. And when you look at the people that are cases, you'll see that a good close to 50% of them have had their vaccine. So we obviously know the vaccine can't prevent infection, but what we have seen is that it significantly reduces hospitalization rates and death rates. And that's what these statistics are trying to show. When we look at the number of deaths in Maryland, there's been about 1.2 million cases. Positivity rate, again, is around 10% now. We have plenty of volume for testing. The deaths have been about 15,000. Currently, hospitals are enjoying low rates of COVID hospitalizations, including acute care and intensive care, both in the adult and pediatric age groups. This is an example of Shady Grove Medical Center, their rates of infection over the past 60 days. And you can see that things have really significantly quieted down. By gender and ethnicity, we see that this disease pretty much is killing older individuals, and 85% in the US of all deaths are in population 65 and greater. And there has been a disproportionate number of African Americans and Hispanics who have been initially victims, who've fallen victims of the disease. But that is also changing, and there's more recent data is suggesting that because of the vaccines, we're seeing more a representative sample of the various ethnicities with respect to cases and deaths. So that's good. Breaking it down to deaths and cases by county, you can see Baltimore, Baltimore City, Montgomery, Prince George, they and Anne Arundel, they make kind of the top 5 counties where population is, as well as where we're seeing the cases and deaths. So that these are the areas that have always overwhelmed us from a medical standpoint. So getting to the CDC and ACIP decision-making process, they are doing a better job of being transparent. This represents a distillation of about 131 pages of data that they used in order to make their determination. Part of it was that as of August, they're seeing that we have 94 million cases in the US. We can see where Alpha and Delta played a part in it. And now with Omicron, we've seen a lot more cases, because it's a lot more infectious, but it's not killing people like Alpha and Delta did. The weekly trends in hospitalization are also showing that now the rates seem to be more reflecting the older age groups, because their immunity is waning from the vaccination benefit that they enjoyed. And so there is a push to try to get them to accept the bivalent vaccine, which is out as of the beginning of September. When we look at in June, the unvaccinated adults over 18 had a almost 5-fold higher hospitalization rate compared to those that were vaccinated with at least 1 booster. So it did show that the vaccine was having a positive effect. From looking at age-adjusted deaths in vaccination, the same thing held out, but it was 8-fold benefit with respect to death in those that had received 1 booster dose compared to the unvaccinated. The age-adjusted deaths based on first and second boosters are showing that the more boosters you get, the lower the chances you have of dying of this disease. And this is the breakdown by age group in the population, and this 30% really reflects the 5 to 11 age group. They're lagging behind. There's been a lot of push to vaccinate them, but the data doesn't support it. And they haven't changed, the administration and CDC haven't changed their push to get those kids vaccinated. But the reality is that this disease does not tend to prey on the young. And so we're more concerned in this age group of side effects from the vaccine. The percent of the population that has completed the first booster is reflected here by age group. And obviously the over 65 have been more positive about seeing the value of getting the boosters. And with respect to the second booster, the rates are lower. It's getting to be a harder and harder sell to get people to get the second booster. Some of it is because there was the word out that there was a new updated vaccine that was coming out. And others felt that not only did they have the booster, but they also got the disease. So now they had both natural immunity and vaccine immunity. So they were feeling pretty good that they had a good combination of protection there. There are also observations that were made. We're looking at the differences between large metro centers and rural centers, and how the death rates seem to be higher in the rural areas, even though the infection rates were about the same case-wise. And they feel that has to do a lot with access to care, to vaccines, and possibly the political atmosphere. The weekly COVID case rate by 100,000 is starting to reflect uh, uh, more representative proportions of the ethnic population in the U.S. So I think we're making headway there with respect to this disease. The hospitalization rates also, I'd say what this is trending is that these bars simply are now reflecting more what the true percentage of that ethnic population is in the US. So just another way to support that argument. The weekly adjusted death rates are showing less evidence of disparity, and this is sort of a blow up of this particular area, which is quite impressive that, it's entering a very quiescent period. So the ACP supports bivalent boosters for all of these reasons that I mentioned. And I'm just sort of summarizing all of these. There's an argument that if we can vaccinate people, we can maybe prevent another hidden pandemic that is present in the US, and that is the long hauler disease. 1 out of 5 adults in the US and 430,000 Brits have been hit hard with what's called long haul disease, which manifests 60% fatigue, 50% neuropsychiatric symptoms like mental fog, memory, sleep problems, anxiety, depression, headaches, dizziness, smell and persistent smell and taste disorders, 30% muscle aches, 30% shortness of breath. This impacts significantly and will impact significantly the economy and our workforce. So I think that the argument is that if we can vaccinate them so they have a less severe disease, they're not likely to get the long haul disease complication. That's the same argument that we would use with giving Paxlovid, which has been shown to mitigate the disease intensity. It may actually show a dividend by reducing that long haul complication. All said and done, there's also a developing paradox. It's kind of like you have this bivalent booster. It's been released ahead of schedule, but the public is showing more increased concern about the safety and efficacy of these vaccines, especially in the absence of upfront phase 3 trial results that were present with the previous vaccine. So when we received the other vaccine, there was data to show that it was working. Right now, we don't have that data, though that data will be looked into. It's going to be after the fact. So it's a hard sell when you don't have the data to prove that it works, and you're relying simply on biosimilar biologics as an argument to say that it's likely to work. Despite this, there's been some recent polls by the RAND Corporation and others that feel that 60% of the US population still feels FDA is doing their job to ensure safety. And they feel that a good 75% of the people over 50 will accept this vaccine. There are resources that I am showing you here that you can go to get all of this information. Maryland breaks it down into high-risk areas, conjugate living facilities, prisons. They also are essentially just dealing with the families too. So good resources. The CDC material probably answers any other questions, as well as the Johns Hopkins resources. There's other resources for the vulnerable populations. So this just kind of goes through resources if you want it. These slides are PowerPoint is available to anyone that wants to look at it. Alex is going to make sure it gets onto our site. That being said, I was wondering if there's any questions that anyone has with this brief overview.
Jeff Orlick, KZ3IXO.
I'm listening.
Yes. So right now, I'm well over 65, and I have an opportunity to get a flu shot and a COVID shot. Is there an order in which I should get them?
One in each arm at the same time.
That's the recommendation?
It was known over a year ago that you could actually give the flu shot and COVID shot together. And though they don't have a formulation yet that has them both together, and I doubt that they will, it could be given. And I've been recommending to my patients that if they're going to go get it, get the flu shot while they're at it. I think the honeymoon with flu is over. For the past 2 years, we haven't had a flu season because of what we've been doing with distancing and masking, which has really helped reduce a lot of respiratory viruses like respiratory syncytial virus in children. But I do think that my recommendation would be get them both.
I have that on my list.
Any other questions?
Yes,
Yeah.
yes, Michael, this is Dave Hyde.
Yes, Dave?
I have had, I got the primary series and I've had 2 boosters, and I took my flu shot with the last booster last October. I'm sorry, last October I had I had the first booster and the flu shot. And then in April, I had the second booster. So I had 2 primaries and 2 booster. Should I continue that 6 months, every 6 months, look to see what's out there and possibly get the bivalent at this point? Which
Well,
I did do in October.
Well, they're not offering any of the previous vaccinations that you had because they're really not aimed at the current circulating variants. The bivalent is targeted against what's circulating now, and it probably do a better job with any subsequent variants. So the recommendation is if it's been 2 months since your last booster, you're eligible to receive this updated.
That's us.
Thank you.
Michael?
Yes.
Joe Signorelli, ABC 3CR. We were sequestered for 2 years, and 2 weeks ago, my wife and I both got the virus. It's been now 2 weeks, and I still test positive. Are we contagious? And how long does it take to be non-contagious?
Well, which test did you use? The home antigen test?
The home
Lateral
antigen
flow?
test.
Okay.
Yes.
You are still infectious. The antigen test is actually detecting virus. The PCR test only detects pieces. It detects virus, but it unfortunately also detects debris from dead viruses. So that can stay longer. I can tell you that it's not uncommon, especially if you're on certain medications like steroids or targeted biologics that drop your immune system a little bit, that you'll be shedding the virus a little longer. Usually it's no longer than 2 to 3 weeks. It'd be unlikely that you could go that far out and still shed. But also the amount that you're shedding has been studied, and it seems like even though you're shedding, you're not really as infectious as you were initially. So yes, the answer is you're infectious, and the antigen test is probably, I would not do it any more than every other day because it doesn't change that quickly, and it saves you having to do the test. Now, there are 2 strategies that CDC has recommended. One is the no test strategy. In other words, you just count the days from the onset of your symptoms or when you actually were found to be antigen positive, but you don't subsequently test afterwards. And then in 5 days from that point of initial positivity, you can go back to work with a mask for another 5 days, protecting yourself with the mask, protecting others by using a mask. And then at that point, they say you're cleared to just return to work. Now, obviously, there are people that are going to be shedding longer, but their CDC's feeling is that they're not really shedding that much to create some type of event, a super spreader event. Then there is the testing strategy where it's used mainly in healthcare centers where I have to show that I'm antigen negative before I can go back to work because I'm dealing with people that may be very sick, may be very susceptible. So I wouldn't be concerned about it, but I think it tends to occur mainly in people who are over 60, where you see the shedding occurring longer. Young kids, teenagers, they get over it quickly. They stop shedding very quickly, and it reflects their very robust immune system.
Do
I
two
don't know if
people,
that answered your question.
do two people living together continually reinfect each other?
Nope. You can get out of the basement and get back into the first floor. I think the main thing is, especially, and everybody's going to clear a little differently. I went 2.5 years without getting COVID, and 2 weeks ago I got sick, and I went to the emergency room, and then I went back to the emergency room and was hospitalized. So with cytokine storm, and it took me several days to lose my antigen positivity. So all I'm saying is that as you get older, you don't bounce back as quickly.
Cool. Thank you, Doctor.
Any other questions?
Yeah, Dr. Sauri, this is Fred KA3IXO.
Yes,
With
Fred.
regard to the simultaneous influenza vaccination and the new bivalent COVID booster, I assume they can both be given the same, even if you're like in the group that gets the high dose.
Correct.
Okay.
In fact, you need the high dose because your immune system needs a little more of a kick in order to get to the same level of antigen response. But no, there's no reason to be concerned about the dosing.
And just curious, what's the current thinking about the antibody titer after you've gotten, the booster? Would one expect that it keeps going up, or does it really not matter? They've never determined any particular level that's really meaningful.
Well, the problem is that there is a test, but it's not commercially available. It's in about 3 or 4 universities. Considering the fact that there's been this Wild West show of antigen kits all over the place and PCR kits all over the place being marketed, no one has actually marketed the type of test that you're asking for that would actually give us a level to say, I'm immune, I'm good, and I don't have to worry about it, worrying about a booster. So that kind of quantitative antibody test, it's a neutralizing antibody, isn't available to the general public. And it creates a problem because what is available are these qualitative tests that may be positive because you were sick, or maybe it's positive because you were vaccinated, but the level itself doesn't mean anything. It doesn't mean that, okay, because I have it, I'm immune. It doesn't give us what the answer we're after. Hopefully, in the next year or so, they'll have a test like that. We have it for like hepatitis B. We
Right.
can tell, if we need to have a booster, if we've fallen short of our level of immunity and need a booster, but we don't have that test yet.
Yeah, I think LabCorp was offering one that was a semi-quantitative, but they do warn you, we're going to give you a number.
Yeah,
but
that
it's
the
not been determined
semi-quantitative
as to what that really means.
Yeah, the semi-quantitative tests are not helpful.
Okay. Thanks.
Doctor, if you got if you get the half dose of Paxlovid, does that make you less immune?
You mean if you had already received Paxlovid?
I got Paxlovid, but because of AFib and ZTAC, they gave me the half dose.
Right. I think that the problem that we've seen with rebound with Paxlovid is because some people need 10 days of therapy, just like they need 10 days of Tamiflu, not 5 days of Tamiflu. And we just short-sheeted them because the Paxlovid only comes in 5-day kits. And since no pharmacy is going to give you 2 kits to go back to back, there are going to be some people that break through. The Paxlovid didn't treat it long enough to get all the virus. And so you get a little bit of the rebound. But the rebound hasn't really been as serious as we've seen. But again, I'm in that same situation that you were in. I went into a cardiac arrhythmia, and I was on Paxlovid. But I'd already completed my Paxlovid, and it was more, complications of the virus itself causing a huge cytokine storm that created the arrhythmia. So, like I say, it's everything's a two-edged sword. All medications will help you and hurt you. It's the dose that makes the difference. So I think it was probably more related to renal function, and they're being a little careful not to hurt you with medicines. But I think the Paxlovid in my patients has been a wonder. Within a day to 2 days, they're feeling so much better from it. So just to be clear, the bottom line is I would certainly recommend that if you just had COVID, like you said you and your wife had it, you should wait 3 months to get the updated vaccine. That's what they're recommending. The reason they're saying that is you just had a booster. Your infection essentially was a booster. And so in order for you to get the more bang for the buck for the updated vaccine, you want to give it enough time so you get a really good amnestic response when you do receive the vaccine. You get so waiting a little longer actually gives you a higher immune response, a boostering of your antibodies. So you should wait 3 months. You should get your flu shot, but you should wait 3 months. If you just had the disease like I had, I'm going to have to wait 3 months. And that's the recommendation from CDC. But it's a one-time boost. That's all they're really looking at with respect to this updated vaccine. Should get the job done.
I hate to ask you another question, but a technical question. When you take the antigen test, does the strength of the lines, or when they come up, have any effect? Does that mean if it comes up fast, does that mean you got a lot of virus?
Yes. So we call that a flash positive. If within a minute your bar turned positive, you probably have a lot of antigen. So I would kind of stay home and isolate yourself but you can't give this disease to someone in your household who already had it. I mean, you can't give it to someone who's already had it. So both of you can feel comfortable sharing, things in the kitchen and stuff like that.
Interesting, the 3 months.
I actually got mine from my wife, and she cleared it, within about 5 days. And it took me, a good 10 days to clear it. So everybody's a little different. But then she's a lot younger than me. At least she likes to remind me she's a lot younger than me.
How old is he? Tell him how old you are.
Well, I personally would like to thank you, Doctor, and Alex, thank you for bringing Dr. Michael on the show.
Yes, thank you.
Great.
Quite welcome. Thanks for inviting me.
Oh, so doctor, you have the slide here for monkeypox update. Were you going to do that also, or are you going to say that for another time?
Oh, you have that up there?
Yeah, it's up here.
Oh, I'm
I think
sorry.
that people were waiting because they thought maybe. we were
Oh,
gonna do
okay.
that
Well,
next.
I didn't hear any bites, so I wasn't going to talk about it. But I can, there's a lot of concern about monkeypox. I'm trying to, let me get to that. Okay, so the different, this isn't our first rodeo with pox virus and the gay population, men who have sex with men. Back in the 80s, when I was a young ID guy, I had 900 AIDS patients, and 30% of them had something called molluscum contagiosum. And that is a pox virus in the same genera, same species, family as vaccinia and smallpox, cowpox, cowpox, monkeypox. So when monkeypox came in on the scene, we had already run across it in the U.S. a few times from imported Ghana rats as pets and things like that would come into the Midwest and infect a bunch of other pets in the pet stores. And then the little kitties would end up getting these pock marks due to monkeypox. And we were able to obviously control it because it was pretty clear where it came from. And then that was it. Most of the activity was always either in Western or Central Africa. Around the May timeframe, things started to break out, and they started to see monkeypox in countries that had never seen monkeypox before. And the problem was that it was being transmitted in a very tight community, and it was mainly men who had sex with men. 99% of the cases in the first 2 months were men, usually between the ages of 25 to 40. And the lesions were always genital or oral. And so this was acting more like a sexually transmitted disease. The advantages that we had with monkeypox is that we had just had 2 years earlier a vaccine, a better vaccine, an easier vaccine that we could use. And we had a new type of treatment that was a lot user-friendly, less side effects that we could use for the pox virus. So we had these two already in our armamentarium. And at the same time, the difference between monkeypox and COVID was that if you got monkeypox, you were immune for about 4 years. So a victim who gets it, when he recovers from it, he can't give it to anybody again, and he's not susceptible of getting it over and over again, like we've been talking about with COVID and breakthrough COVID and things like that. So we have an excellent vaccine that can give us immunity for 3 years. It's a different type of virus. It's DNA, not RNA. So its mutation rate is very rare. So even though they talked about some variations in some nucleosides, it really doesn't tend to cause variants to form. And its rate of transmission is very low, whereas COVID, the variants are almost as as bad as chickenpox, with an R naught value of 10 to 15. This thing has a very low transmission rate. And it's right at the cuff where it may just burn itself out. If it falls a little bit below 2, you pretty much won't get an epidemic persisting. The other thing is that there's no airborne characteristics, a method of transmission of this. You can generate any, or you can cause any disease to be aerosolized. That's what biological warfare is all about. Countries are trying to take a human killer and make it worse by aerosolizing it. But with this particular disease, historically and currently, it's by direct contact. And even when they looked at sampling of household things like dishes and doorknobs and things like that, they weren't able to see any transmission that way. It has to be by direct contact and prolonged contact. It also doesn't tend to cause as much hospitalization as COVID. Most of the reasons people get hospitalized is they're in terrible pain. They need narcotics for the pain that they have because of the lesions are in the genital areas or in the mouth. And our biggest concern is, even though it has stayed even now in the population of men who have sex with men, we always worry about it spilling into the sex industry, or it gets into prisons or childcare centers where it can amplify and create a problem, especially when there's a lot of continual contact with low hygiene. So that's the big difference between these two. We actually are seeing a drop in monkeypox cases even now as we speak, but they are primarily been in the US, limited to New York, San Francisco, DC, and the larger metropolitan areas where there has been a large, consistent gay population. So that was sort of just a quick and dirty thing on monkeypox. If for most people, it's not going to affect them. Maryland has about 460 cases. Most of them are in Baltimore. And DC has probably 3 times that number. And New York City and San Francisco have a lot more, LA a lot more. So again, like I say, that's just a quick and dirty on monkeypox. I didn't really want to spend too much time on it because I wasn't asked to talk about it, but that's all I spend my time doing lately, at least since July, is giving podcasts and to organizations and talking to them about monkeypox and a little more detail. I do have a bunch of other slides that talk about the Maryland experience, the US experience, the global experience, but pretty much hopefully in the next month or so, because the communities that are at high risk have gotten the word out and have started to limit their exposure, hopefully people with the characteristics of this virus will be able to see it go back to its reservoir, which is essentially Africa. And it's not really monkeys, it's probably more rodents. Monkeys just got the bad rep because that's what they saw back in 1958, was it in monkeys, but the monkeys probably got it from the rodents. Any questions about monkeypox? We haven't seen one in our hospital. Okay, just to let you know, we're not, it's not an epicenter, but there are epicenters for monkeypox, and it tends to be in the mega urban centers. There are other things like polio in the wastewater in New York City. That's been of interest, and that mainly I think is a collateral damage from COVID. Our kids aren't getting vaccinated, the parents aren't taking them to be vaccinated, or they're focused on vaccinating them with COVID vaccines and not doing their childhood vaccinations. So hopefully we'll get that under control too.
Speaking about polio, I was just reading the UK recommendation that kids under 9 get vaccinated. Is that simply because young kids these days are not getting the vaccines they need, as you just said? And really my question is there any reason to doubt the continued effectiveness of vaccines, like mine that was received, 50, 60 years ago?
I agree, and a good question. Generally, the recommendation to give a additional dose of polio is usually when there's an outbreak of polio. So if you see it in the sewage, you know that it's been around for a while, and that there's probably a lot more activity that we're just not seeing. Because the reality is that only 1 out of 200 cases actually develop paralysis. So there's a lot of kids get polio, poop it out, don't have any illness, but they essentially spread it to somebody who is going to get paralyzed from it. So it isn't a given that just because you were exposed, you're going to get the disease. But generally, the recommendation for travelers, if you're an adult, you're over 18 and you haven't had a polio booster and you're going to Afghanistan, Pakistan, Africa countries, Eastern Africa, like Yemen, you need to have a polio booster because there's a lot of activity in those countries. We've been trying to eradicate polio for the longest time, but war, pestilence, all kinds of things get in the way. We had the same problem with smallpox before we eradicated it. Somalia was one of the last places, and they were in war, as they still are. So a lot of it is now just catch up and making assumptions that, well, if we don't have medical records or if they've missed a few shots, let's go ahead and just give them 1 shot. The oral polio, the Sabin vaccine that we got when we were, well, I'll date myself, but I remember the Salk vaccine, which was a shot, and then the schools 10 years later, they would put the virus in a sugar cube and we'd all have to go and get it. And that was the Sabin vaccine, the oral. We stopped giving the oral vaccine because we had more paralysis from the vaccine, the polio, than we did from wild strain polio. So a good 20 years ago, we stopped giving oral polio and only giving the inactivated polio. So when they talk about getting the polio vaccine, they're not talking about oral polio anymore, because that now our rates are so low that the only polio we were seeing was the live vaccine polio. Some kids who are immunosuppressed, you can take an attenuated virus and it'll kill them. It'll act just like a pathogenic virus to these kids that have an altered host. So, as I mentioned, we're not talking oral polio, we're talking inactivated polio boosters.
Okay, do we have any more questions for Dr. Sauri?
What a fabulous resource and great presentation. Thank you so much.
Yeah, unbelievable. Thank you,
Well,
Doctor.
thank you.
Thank you.
Very, yeah, I wish I had a doctor like you because you're so patient, so thorough, And you explain everything in very simple language, you know, that is comforting. At the same time, you're like smarter because of it. So thank you very, very much for taking.
Thanks. I appreciate it. It's always nice to see everybody. Maybe one day we'll be in person. All right.
God willing.
I'll talk to you later.
Thank you, Doctor. Okay.
Bye-bye.
Bye-bye. Wow, that was terrific. That was terrific. All right. So I know I'm smarter now and actually more comforted because, you know, hopefully this was optimistic and we're on the glide slope toward the end of this, which would be very nice. 2.5 years is too long to be apart. Okay, so are there any more comments before we close for the evening? Okay, well, thank you for everybody that came, and thank you for everyone that had their thoughtful questions for the doctor. Any objections to adjourning the meeting?
For me.
Okay, all right, so the meeting's adjourned without objection. Good evening, everybody, and 73.
73 is from Florida.